Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about adductor strains from differential diagnosing, because there's even diagnosis within that diagnosis, to treatment and expanding further to performance. But before we get into it, Brandon, how's it going?
Going well, man. I like how you pointed to the side there. It's great. I love it. Stuff. Yeah, we got an early morning one for you guys here. So we're drinking our coffees here. What'd you go out for your coffee?
Looks like a place called Lucky 7.
Okay.
You know what? You probably pass it on your way to coming in here, like visiting my house, like if you come off of Parkway and that sort of stuff. So Lucky 7, small little deli.
Nice. Yeah, I usually swing by the Wawa. That's there.
So if you go a little bit further, Lucky 7, better breakfast sandwiches, coffee's just as good. So that's the spot you want to go to.
All right, I'll check it out.
I will admit it is not of the caliber of North Jersey breakfast sandwiches. I'll say that on to the thousands of viewers here. The quality of breakfast sandwiches in the North is superior.
Our Taylor ham.
Yes. So I'll still stick to my guns. It's still pork roll, but you do make a better sandwich.
All right. I just have an espresso, but I have it in my Colorado cup here that I picked up in my many trips to Colorado when I was doing my fellowship over at Regis University. I'd say this one and my Sam's number 3 coffee cups are like 2 of my top coffee cups.
Sam's number 3, huh?
Sam's number 3. I frequented that diner.
Yeah.
Breakfast, lunch, and dinner. They had everything there. It was amazing. Me and Raph and I would go literally constantly.
That's in Denver. That's in
yeah.
All right,
downtown Denver. I should have told you to go there. You just went.
I know.
I've told you about it before, but I forgot.
I have a brother's trip in July with my 2 older brothers to the mountains. Like we're going hiking and that sort of stuff. Okay. I'm putting it in my calendar right now. You keep talking about it, but I need to put it in because now I'm so disappointed I missed out.
I think there's 3 of them, hence the name number 3. But the one I went to was in downtown Denver, like in the city area and downtown, awesome food. I kept getting the Trailblazer. They have like these biscuits with country sausage gravy. It's freaking amazing. Their dinner's good. Like literally, I think one day I had like breakfast and dinner there.
Wow.
Lunch we were in class for, so I didn't get lunch. Otherwise I would have. But yeah.
That's impressive.
Definitely worth it.
Yeah, I put it in.
I will say this: their coffee's a little suspect, but other than that, everything else is phenomenal. Get their graham cracker milkshake too if you want to be a fatty.
I wrote get the Trailblazer, and then I'll put in what was it? Graham
cracker? It's like a graham cracker or like a s'mores milkshake. I don't know. It was fire though.
All right, it's in.
All right.
Thank you, sir. Can't miss it.
All right. So now that we've talked about coffee, cups, and food, we'll go on to our podcast of adductor strains. I love particularly differential diagnosis. But before I get on my soapbox there, anything you want to lead us off with or state in terms of adductor strains, clinical? I'll just run into differential.
Yeah, I mean, this is a fun one. I think something that's maybe all along the lines of overdiagnosed or trying to, almost umbrella term any pain into the general groin area, and you can add the athletic pubalgia into this group. But even if it's a true diagnosis of any of those adductor groin strains, there's diagnoses within that, and that should specify your treatment versus all right, cookie cutter, everyone needs to do Copenhagen's and everything like that. Try and get real specific, and I'll let you dive into that. But I think from what I've seen, where I've had you and me both, Brandon, and we tend to be in our clinics or our patients or clientele tend to come from other places, and the ones that those pesky adductor or groin strains that just haven't gotten better, and they then decide to come to us, there's usually something that was missed. And we'll talk about that with differential diagnosis. So hopefully this is everyone listens in, because I think usually people chalk this up as kind of an easy one, and then you just, when it pulls again, it pulls again, and you rinse and repeat the same program over and over and over. And if you look at a lot of the guys, especially in the pro realm, it's like they get out and a couple months later it's the same thing. It's almost not nearly as bad as hamstrings, in my opinion, or those calf strains. Those people, it's just, so you just see it, it's like, well, they're out again, but adductor, especially in the hockey realm, those people are probably a close, I'd say a close third in the chronically repeated strain category, if it's truly strained or not. But yeah, that's my mini pre-soapbox before your soapbox. But
yeah, I feel bad for those chronic adductor or hamstring strains. I mean, you look at I think we're going to do another episode on hamstrings, but you look at like Jose Reyes. I know this podcast is going to go a little later, but right now Devin Booker, the Phoenix Suns, is out with his 5th hamstring, so he's missing crucial time in the playoffs. And it's like 5 hamstring strains. I was looking at the mechanism, didn't really add up to, like, he wasn't, I mean, he was sprinting, but it wasn't a powerful sprint. It's not like he's a track runner. To me, that this is coming from the low back. Something's being missed, and like you said, you do your standard treatment. It's an umbrella term. If there's no blood, right, because of an actual grade 3 tear, I really question some of these strains. And if it is a strain, it should probably just heal in like a couple days. Right? Think about acute healing, like it really should just heal up. So it makes me think that we need to do a better job with our differential. And an article that stood out to me in this region was when we went to fellowship. They're not fellowship. We went to residency, and there was an athletic pubalgia article. But yeah, same region. Forget the fact that it's athletic pubalgia. It has a great differential diagnosis section. And it really, and this is a couple months into clinical practice, it has stood out over 8 years on, we need to do a better job of differential diagnosis things, truly trying to do our best to rule in and rule out, and not just, it's an adductor strain and just treat a big region, because you have so many muscles in there that are technically adductors. So like you said, within that, is it the pectineus, the gracilis, the adductor longus, brevis, adductor magnus, right? Like there's so much tied in there. Yeah. Which one really is it? Does it matter? Is it even that? Or do they have other impairments such as tight hips leading to it, poor lumbopelvic coordination, control, stability, we'll say that in air quotes? Are they having something from the lumbar spine? Right, so that are leading to these areas being strained, right? Instead of just treating the soft tissue, for all you soft tissue junkies out there. All right, don't limit to yourself, don't limit your treatment to that, but we'll dive into treatment later. But just some things, I mean, just off the rip here, anything in the hip region that it could be, right? You have bursitis, you have snapping hip syndrome, you have labral tear, impingement, often, again, big umbrella terms as well. You have your neurological type stuff, lumbar pathologies or lumbar radiculopathies, you pudendal or genital femoral neuropathies, which we were having a side conversation of a case you're dealing with, obturator nerve pathologies, ilioinguinal neuralgias, right? You have your adductor strains, your iliopsoas tendonitis, tendinosis, rectus abdominis strains, right? All these things that need to be going through your head to help rule out. And then you have your maybe more serious pathologies, your avulsion fractures, stress fractures, femoral head fractures. Those you should probably send out to get MRI and imaging done to help with that. Though patellar pubic percussion test might be able to give you a clue on stuff like that. But I mean, right there, that is a mouthful. That is that should take you 10 minutes to go through that differential diagnosis and make sure you're not missing anything and before you start treating. and you get that script, oh, it's an adductor strain. Like, that's so easy. That's type 1 reason. That requires no thought process. So next time, you get therapists out there and you guys get someone who's like, oh, I strained my groin, great. They're telling you the region where their pain is, but as you often say, Jeremy, pain is a liar. A doctor spends, physician, let me rephrase that. Physician will spend, 5 minutes max with a patient and write a script for an adductor strain. Great. Your job to go a little deeper and try and, rule in and rule out and hedge your bets on where do you think this stuff is coming from. And I'll tell you, it's probably most of the time hip, pelvis, lumbar, spine that we need to be treating instead of the soft tissue. Not to say you can't do a little work to that area, but you need to be looking at other areas.
And like, if you haven't been exposed to many of these acute ones or ones that are pretty definitive, ask your patients, especially ones with chronic issues, get a good story of how they came to be to you. You'll have so many times where someone, classic, I mean, probably not as much as, adductors, probably not as much as the classic hip flexor, or hip flexor tendonitis, tendinosis, tenderness, tight hip flexors, whatever you want to say. And then they try treating that for a while, and then eventually it's like that's for months, and then they get imaging and they're like, oh, it's a labral issue of some sorts. Versus, so did we even really need to know that was a labral issue? Could we have figured things out the first time, maybe done some hip mobilization, spine, soft tissue as well if you want, and prevent that thought process? Because let's face it, once you know you have a labral issue, it kind of changes your trajectory of your life. I just saw a good article on from Dr. Howard Lukes. I think we talked about this last one. You can't unsee your image. So a lot of the time, like, these people, these chronic muscle irritations or strains and that sort of stuff, they go through the paces and they do it round after round until eventually they do more imaging, and then this whole time, it's been more of a joint based thing or something of that nature. So that's, something to keep an eye on. If we're truly this autonomous primary practitioner, it's our job to figure out the first time to avoid, the need for further imaging and further medicalization and planting those nocebo thought viruses of, well, yeah, I've had this pain for a year. Now I got all these images and I've come up with 3 diagnoses. So, really take it into account, like really listening to those people's stories. And then you can really start to see like, oh yeah, they may have presented with that classic groin strain, and then they didn't get better clearly with other interventions. And now they've got lumped into 4 other things. But that's something I especially when I started doing a better job of listening to my patients and diving a little bit more deeper into their history, I started to find that out a lot, especially more with the hip flexor component than the classic adductor.
Yeah, as you were talking, I just I think we're at a crucial time here in 2020 in the medical world, especially with physical therapists or conservative treatment. We really need to start questioning and challenging the medical model and pathanatomical model. Like, even till this day, we're being taught stuff that the origins were from like 50 years ago, 70 years ago. Like, we've advanced, just in so many different ways and realms that we should really start challenging some of these traditional diagnoses, especially pathanatomical. And like you said, listen to the patient and find out where the origins really are. It's like hockey. You get a hockey assist, right? The assist that led to the assist for the goal, right? Like, well, what's the problem? What's the impairment? What's the history leading up to what led to the injury? Let's start looking at that and not the injury itself or the complaint itself. But again, getting that bigger picture, that patient communication aspect, and trying to discern from there what's really going on.
I had in a semi-related note, I had a patient last night or yesterday Um, she had she was trying to relate it to, she works out, body builds, does some powerlifting, had left hip pain. She related to after a C-section. And then she said after with further discussions, a lot was going on when pain started. Divorce, C-section, is a nurse during a high trauma place, and then COVID nurse, such and so forth. She was talking about like hip flexor, also point towards her groin as well. Then started developing right hip pain, and also reported the back. And instead of just going in, she's like, oh yeah, working on it and that sort of stuff, instead of just doing exactly what she's doing herself, which adds no value. I mean, anybody can get so right. That's the thing that digs into there. There's every gun available now. Guns, the massage guns are what, not even $100 anymore. There's tons of tools out there. Actually, I was assuming, there would be more lumbar stuff with her. It was actually on the original Evolve side, a ton of T-spine stuff. I worked her T-spine and instantaneously pain-free squat. I also did some hip mobilizations because I found out that, a lateral glide afforded her almost 10-15 more degrees of pain-free flexion. But, me not assuming it's like, oh, it's, just someone who's overworked, tight hip flexors. She got a ton of benefit in that first session. So, make sure you guys think outside the box for these things that are labeled easy diagnoses, because you can do eccentric hip flexor work, or again, the whole protocol for adductor strains, and that is what the whole Copenhagen series. I don't think that's changed too much. Isometrics to eccentric loading, especially for sports, and try and work on decelerations and your brakes essentially. But if it keeps reoccurring, and let's face it, the athlete probably, let's say, before the injury never really worked on this stuff, and then in theory you got them more capacity and increased their eccentric loading or capabilities, and they're still experiencing the pain, or it's still reoccurring. It's probably not the muscle truly being the issue at that point. It's probably something else. In this particular individual, what really cued me was she had notable like atrophy of her right quad her left quad compared to her right. So that's clearly something else, unless again she ruptured her quadricep muscle, or had an ACL surgery and something like that. No, something up the chain is leading to decreased input to that whole left lower extremity. So, think outside the box, everybody.
And I'll even add to that, let's say it is a strain. Let's say these things are strains. Let's say these things are tendinitises, tendinopathies. It's a reason it's being overused. It's working too hard. So the chances are it's probably not as weak as you think it is. And yet, what do? Oh, let's strengthen it more. Let's improve the capacity of that area. Fine. But if it keeps happening, chances are we have to work to offload that structure or those structures that keep getting strained because they're working too hard. Well, why are they working too hard? Well, other regions are either limited motion wise, or to use the term balance, restoring muscular balance, or timing, synergistic timing, right, of the antagonist muscles and things like that, is what's going to help. So if you look at hamstring strains, well, why is that hamstring keep straining? Well, are the glutes not working enough? Is there not enough motion in the hip, right, to fully extend, right? Because it's a 2-joint operator. Same thing with the adductors, right? Except adductors are typically 1 joint, but is there not enough motion within that hip, internal rotation into abduction, even adduction? Is there not enough lumbopelvic rhythm, or control, or motion to extension, which may be limited, like you said, by the T-spine? Are the abductors not working enough, or working when they should be? Are the abdominal muscles not stabilizing where they should be, where the adductors need to kick in more and work kind of overtime? So we have to start thinking, why is this muscle getting strained? Well, it's an overuse thing. Tendinitis, tendinopathy, it's an overuse thing, right? So if it's an overuse thing, why do we just keep on strengthening that area? Like, let's take a step back and treat something else. Um, so I come from that approach a lot of times. Like, let's start doing things that other people aren't doing. Like, and that
Exactly.
goes to asking your patient, what have you been doing? Well, I went to this other place. We did a bunch of exercises. Great. Well, I'm not going to do that. Let's do something else.
Mhm. I couldn't agree more. I think with me examining and having an impairment based model, like, all right, what's truly the issue with the patient? I find more issues in, let's say, adductor strains of like your hip abductors, hip extensors, the core, like with those muscles, on the involved side compared to the other. All right, yeah, if it's truly strained and it's weakened and got lengthened real quick, yeah, that should obviously be weak, but the surrounding musculature is even more weaker compared to the other side. So that suggests, again, it's a whole system. If someone's not working, someone's going to pick up the slack. I always kind of link it as a group project. If two members of your group aren't working, causing the other people to work more, they're going to be pissed off, annoyed, angry, and that's pain and discomfort.
Yeah, yeah.
um so it's just something that we need to look at. I want to bring up something, especially on the research of strain articles and a lot of these things, especially these crazy eccentric programs and whatever it may be. A lot of it is, we have to take also into account of, natural spontaneous healing, but in a lot of the articles, they have their cohorts and whatever like that, and then they just base the research off of the people who complete the studies. A lot of the time, obviously, if you drop off, you're not included into the results of it. So how
Yeah.
many of the people who drop off, like say start off with 100 and then you finalize with 60 that dropped off because they weren't getting results? Oh yeah, the 60 that did this eccentric program, they had great results compared to the ones that did nothing at all, or did concentric loading or whatever it may be. What happened to those other 40? Yeah, they dropped off, but what was their rationale? I think we need to do, I don't know if it's possible. Oh, I'm sure it's possible. I think we need to do more research in the drop-offs than we do on the ones who kind of stick it out. Because if we chalk up a lot to spontaneous healing, and you look
Yeah.
at some things of like general exercise is just as good as specific exercise, or general techniques are just as good as specific manual techniques. Let's look at the people who drop off, so we can get a real true picture of what saying. Maybe those 40 people that dropped off got worse or didn't get better or whatever, or ended up having surgery. We just like, oh, they didn't show up, they stopped going, fuck them. But that's something, take into account with these, basing all our treatment decisions on these research articles for things such as adductor strains.
Yeah. Yeah. Well said. Well said. I think that kind of covers like treatment. I don't know. Is there anything else you guys you want to kind of dive into? I mean, we're not saying not to do Copenhagen's, not to do all that stuff, but
Love that stuff. And it looks great on the
going
gram.
deeper, into really the beginning part, your basics, making sure you're targeting the right things, targeting other structures, not making your sole intervention just the adductor group with these patients. Making sure they have enough available range within the joint so the muscle can better operate. If that joint's not moving, that muscle, let's look at sarcomeres, doesn't have the ability to work in its full range. Also, a lot of these patients, like we said, they lack sufficient hip extension. Like Jeremy said, he's looking at their extensors. They lack lumbar extension. So therefore, maybe they go into a TL junction or their T-spine. They may lack anterior abdominal control or oblique control. And then for those of you guys who like your slings, maybe you work on some sling strengthening. There's a lot of different things you can do. So we're just advocating not to focus solely on the adductors, as also not just to do a general shotgun approach and just strengthen everything either. Like, have some thought process behind what you're doing.
And if that doesn't make sense to people, like the idea of like, we all know like knees and total knee replacements and ACLs and that sort of stuff, try and get the quad going without like full extension of the knee. We have studies, was that Fluger Life 2021, of doing hip mobilizations that improve hip extensor and hip abductor strength. So, think of it like that. If you're not able to get the full range, you're not going to be able to hit that optimal length tension relationship, fire up the muscles. And it's important for all lives and styles, whether it's athletes or not. So again, try not to just do stuff that anybody can look on Instagram or YouTube, type in, I think I strained my groin, and just find out, oh, it's a bunch of Copenhagen's or isometrics or whatever it may be. Try and, provide that extra value of care, why people should come to us. We're here to speed up the process. Yeah, you keep doing Copenhagen's, after some period of time, you probably will get better. But what can we do to get you better faster and hopefully prevent it from reoccurring? I think that's where our real value is especially for any of the strain categories, is preventing reoccurrence. That's always ideal.
Talking about Instagram and finding exercises, I was actually having a conversation with a coworker of mine, and it's easy to find like, oh, the next trendy, cool, high level, explosive exercise on Instagram. Like Instagram is great for that. 95% of your patients can't do it. So it's understanding, where that patient is, giving them the appropriate treatment at the appropriate time, and understanding regressions and progressions, understanding your dosage, understanding, these strength conditioning principles to get that patient to do a high level stuff. Do they need that high level stuff, or is it just nice and fancy and look cool, but that patient can't do it, and you're actually putting them at risk because you want to try something that's too advanced for them? Great, kudos that you want them to, that you're trying this stuff, but also understand who you're having them try it. We're working with a girl who's, I think she's had 4 knee surgeries, 4 ACL tears, 2 on each side. This is our first time seeing her. And, so we're talking, and it's like, well, she's had 4 surgeries. Like, it's going to take probably longer for her to really come back from it. So, that's how the conversation started. It's like, all right, well, can your patient do this? And then we're just scrolling online, and I was like, better or more advanced isn't always better. We need to be able to do this in a controlled environment before we go do X, Y, and Z. So we kind of got on a rabbit hole of a discussion. And it kind of just made more sense to my coworker. It's like, yeah, like I see what you're saying. I have to do X, Y, and Z with her. And then she came in and we're working, and she was looking pretty good. I'm like, all right, like she's doing well. She just needs to continue. Like this phase of strengthening is just going to be longer for her. Like she has a lot of strengthening to do, where, she's getting a lot of physiologic action tremors. Why progress her? Why? Because she's at 6 months. Like, no, her knee's shaking, her quad's still shaking. Give it an opportunity to grow. Give it an opportunity to hypertrophy, right? Because that's going to lead to increased cross-sectional area, and then increased strength, increased contraction, increased explosiveness. So like, for her, it's just, she's just going to have an elongated time, and that's okay. But we should understand that not everybody fits into these timelines that are made for the masses. Sometimes we have to alter them, which we've talked about in your ACL course, and probably other podcasts, that these timelines are just guidelines. They're not, the 10 commandments.
Like that. Definitely couldn't agree more. This is probably good for another episode on something of this nature. But yeah, I think that covers. Anything else that you want to talk about with adductors and that sort of stuff? Some big points, make sure you do your due diligence and differential diagnosing of things outside of the, let's say, the athletic pubalgia group of, like, the psoas or the hip flexor group, the adductor groups, and all their respective muscles in between. The core as well, you have that's a component of that whole group. But then looking outside of things, a joint, labral OA as well. Spine, look at nerves, obturator, femoral. So look at things outside the box. And then, same theme when it comes to treatment. Let's make sure we're treating the whole person, not just dialing in on just the proposed diagnosis, and make sure you're listening to the patient, kind of help facilitate both examination, diagnosis, and treatment.
Yeah. Last little clinical parole. We talk about the lumbopelvic region. Can that pelvis move in the transverse plane and rotate around the hip joint? That is huge, especially in these adductor strains and rotary athletes and things like that. Do they, or can they just move front and back in the sagittal plane? I found that to be key.
A lot of them can't, like, and you wonder why, and there a lot of people don't even have the ability to dissociate in those particular areas. And I know a lot of purists who are just movement optimists don't really care about those sort of things, and people should move, and it doesn't matter how you do it. I think it starts to matter when it's, your second, third, fourth offense at these sort of things, and I think it warrants getting it looked at, and if addressing it resolves their symptoms and makes them better, I think there's a time and place for that sort of stuff.
Yeah, if you're someone who's never worked out, you're obese, you're just out of shape, yeah, just general movement's going to be fine, right? That I understand when these things apply versus somebody like Jeremy said, higher level or multiple offender, repeat offender. Well, now we need to start looking how you're moving and not just getting you to move.
Absolutely.
All
Great
right.
stuff. All right.
So we'll wrap it up.
Yeah. Listen to our intro there for upcoming courses and information and mentorship and consulting. And yeah, thanks for tuning in, guys. And cheers. Coffee cheers.